So without further delay, I'd like to introduce you to William Roberts, who's the National Care Homes Lead for the new Care Models programme and part of the 5-year forward view. He's an experienced director within the NHS and is a trained nurse and has many leadership roles across the whole of the health system. So I'll hand over to William Roberts. Thank you very much.
Good morning, and thank you very much for a very kind set of words, which is a lot better than the last time I stood up at an event with Chris. When I did that, the person introduced us, as I said, next up is a person who I would describe as the epitome of integration, Chris Badger and William. I didn't get quite as good a welcome last time with Chris, so there you go. I feel a bit better now as a result. So I won't talk for long. I'll talk briefly about a couple of things. My name's William Roberts. For the last 2.5 years, I've been lucky enough to lead this work nationally. In terms of what this work is, well, that's an interesting question. So when I first came together 2.5 years ago to start to look at what we needed to do, I went to the 5-year forward view. The 5-year forward view is a document that tells us we've got 3 challenges. Firstly, people are living longer with greater levels of complexity, and we need to be able to deliver high quality care at volume, which is really hard to do. Secondly, it also suggests that we've got to move away from pulling people out of the water and preventing them from jumping in the first place. And then the third thing it challenges us with is there frankly isn't any more money in the system. So we've got this real challenge. If you go to the 5-year forward view, it says, and by the way, let's try and do something different about care homes, try and get them out of the hospital if all possible, please, ... And I paraphrase, but that is pretty much what it says. So when we came together with our 6 Vanguard sites, we had a real challenge, because what was it we were trying to do? So for the last 2 years, we've been working with them to really look at how do we provide joined up services that work in combination and wraparound care homes. So thinking about the fact that if you go back to when I first nursed on the wards 20-something years ago, I was looking after people in Dulwich Hospital. Those people were then moved out of our hospitals and into the care sector, but what we didn't do at the same time was move with them the NHS services that had traditionally supported them. So we took some of the most complex and vulnerable people, quite rightly moved them closer to home, but forgot to move with it our NHS services to support them. So we've been trying to look at how do we address that. But not just in care homes, not just in residential care or in nursing care, but also thinking about the huge number of people who live in long-term supported living arrangements, whether that's extra care housing, whether that's supported living, whether that's shared life schemes, etc. Because actually this care model, whisper it quietly, isn't really about care homes. What it's really about is about bringing services together, integration, and working together for the needs of the service user. Now, if I ask you a quick question, bit of interaction before we get started. How many people in this room, put your hand up, do you get up because of your fabulous paycheck in the morning? Hands up. No. Okay. How many of you do it because of the sheer kudos of the job you do? No. How many people in this room, though, get up every morning because you want to make a difference? Hands up. And what's fascinating is we've forgotten that. We've forgotten that as a system. We've forgotten that most of the people we work with get up every day because they want to make a difference. And the bit of this job that is amazing, the bit of the job that is great, is everywhere I go, I find people who want to make a difference. So these 6 sites across the country, 6 places up and down the land have been trying to make a difference. And they've started and focused with the people we're serving. But we're also running an innovation programme. Just to let you know, nothing we're doing is particularly innovative. Okay? And that's really important, because actually if you go back and you look historically at how did we start to understand these kind of care models, people have been describing them for years. There's some brilliant documents out there. We've now found 200 different policy documents that describe all the elements of what are being done in the Vanguards. What's different and what's unique, I think, about the Vanguards, and I'm yet to find anybody else who's done this, is they're actually trying to do it all at once in a joined up way. And the problem we've got is that you all want a silver bullet. So everywhere I go, people tell me, they say, William, tell me the one thing I could do that would make the biggest difference. And I crushingly disappoint them every time, firstly by my very presence, but secondly by my response, which is there isn't one thing, unfortunately. What there is a whole series of small things that you've got to do in a combinatory way, and when you do that and you do it properly, all together, all at the same time, you'll find you make a really big difference. But the problem is we seek repeatedly the silver bullet. What's the one thing I can do? And we try to find the answer, when actually the answer is sitting amongst us with our staff already. So doing something different is what the Vanguards have done. The other thing we really discover is it's not necessarily about what you do. So again, I described all the different papers that have said how this care model should work. There was a really good one called The Quest for Quality. I don't know if anybody in this room has read that. Hands up if you've ever read The Quest for Quality. It's a great read. It's a really good read. It describes exactly what we said 2 years later, 2 years previously. The challenge was that actually what we discovered with the work with the Vanguards is how you choose to implement something is as important as what. Because when I go to a place, after having said to me what's the one thing we can do to make a difference, the second thing people say to me when I tell them the things they could do is, oh, we already do that here. And that's really hard, because one of the things we've got to get ourselves beyond is the idea that we do already do that here. We probably don't. We do a version of it. Some of it might be working, some of it might be. But you can pretty much guarantee within 10 minutes of a conversation, we all agree you don't do it. And then the third thing people say to me when I come to them is, okay, so we agree now that there's not one thing we can do. We agree now that we don't already do this. But we do agree that we couldn't possibly do that here and it just wouldn't work for us. And that's a real challenge. How many people, hands up in this room, when listening to something at a conference, have thought immediately of all the reasons why that wouldn't work? How many people have heard the person that works next door to them in the neighbouring borough and gone, oh, you know that wouldn't work in our area, we couldn't possibly adopt that? And you're right, it doesn't. Because you can't lift and shift innovation. You can't take something, pick it up and drop it into another area and expect it to work. But what you can do is you can adopt and adapt. And I can pretty much guarantee that in this room somewhere today is somebody doing something that will solve the problem you face at the moment. The challenge you've got to work out is how much of what they've done you can just take and transplant to your area, and how much of that you've got to vary for your local context. But if you don't believe me for all these other reasons, the reason you should really do this is because actually you make a really big difference to service users. So since we started this work, the Vanguard are now tracking about 6% less emergency admissions than the rest of the country. The number of bed days in which those people are staying into hospital for is nearly 6.5%, 7% different. Now, obviously I come from the NHS, so you'll say, yes, of course, NHS, you're obsessed with hospital admissions, you're obsessed with bed days. But actually what I'm really obsessed with is quality of care. And if you start to think about this, for every day an older person spends in hospital, their functional ability drops. Somebody of 75 who goes into hospital, after 10 days of being in one of our hospitals, they have the functional ability of an 85-year-old. That means the likelihood of them going back to the place they came from, having a high quality of life, and being able to lead the life they led previously is significantly diminished. So getting people out of hospital and keeping people out of hospital is not about savings, it's not about numbers, it's not about spreadsheet, it's about improving quality of life. And the fact that you then deliver better care with better savings and better efficiency for the system are the things that fall out of delivering great care every time. A year ago we published a framework. Hands up if you've read it, be honest. Okay, so smattering of you. The rest of you, get on the website this afternoon, download it. This is one of the easiest reading policy documents you will ever find. It's written by a clinician in really simple language that is understandable. It gives you really practical examples of what to do. And it is the recipe book for how to do it. Now, I'm not saying go from there and just do exactly what it says. I'm saying go there, read it, think about what it says, and think about how you could do that locally. Because we know what we're talking about works. It's based from the bottom up. We didn't sit in a darkened room and create it. We took the work the Vanguards were doing and then tried to turn it into a common set of things that was being done across them. Every single thing in this piece of work has a research evidence base to it. So if you don't believe me, and why should you believe me, go and believe the research evidence. So every single thing in here, we can point you to a peer-reviewed journal article that tells you why that works. So this isn't just about taking a risk or a whim. This is something that has a significant research base behind it. And it describes that care model and how we want to spread it. There's 7 core elements to it and 18 sub-elements. But it's really simple. It essentially says, give people in care homes access to primary care support. Give them access to specialist services when they needed it in a really timely manner rather than making it something you wait for. Keep people out of care homes, because if you keep people out of care homes, you manage care homes better. Care homes need to be for people who really need to be in them, not a lifestyle choice. The fourth thing it says is if you're an older person going into a care home, you're probably there because you're in the last years of life or have significant cognitive impairment, which I can never say. But 75 to 80% of the people in care homes will have dementia. So ensure that if nothing else, for the services you commission around dementia and end-of-life care, they are prioritised for care homes, because that is your single greatest group of people with those needs. It then says, sort your commissioning out. Commissioning is really tough, but also we do lots of silly things in it. So get your local authorities and CCGs working together in the interests of the service user and, most importantly, in partnership with the providers. Think about health and care as a workforce and look at training and development opportunities across the system. And you'll hear today about really good examples of where that's happened and the difference that makes. And not just the learning from the NHS to care homes, but also what the NHS can learn from care homes who bring a completely different perspective to your work. And then finally, it says give people access to technology. So what have we learned? Well, firstly, we've learned you've got to do this based on people. This isn't based on buildings, organisations or structures. You focus on people and you focus on the population in which they live. You've got to get your leaders on board. So I could find in this room 20 brilliant people who will do 20 brilliant things. But if your leaders don't get on board and you don't get people supporting you, it's really hard to sustain this sort of thing. And I could take you around the country and show you amazing pieces of work that have died because they didn't have leadership support. Don't try to do this without care homes. If there's one message you take away from today, work with your care homes. They're expert, they're a resource, but also, if they don't want to work with you, they won't. And this simply won't work. You cannot force people to do stuff that isn't in their interest. You can see the benefits quickly. We think that you can get benefits from this flowing into your system within 6 to 9 months, which compared to most change programs, which take 3 to 5 years to deliver, is a really quick turnaround. But there isn't that one change. We don't think there's anything there, and this does require that coordinated approach, rather than just going out and doing lots of isolated initiatives to try and hit and hope that you'll get some improvements. You can apply this wider than care homes, and it can drive better relationships between commissioners and providers. So I said something a couple of weeks ago at something, and somebody asked me a question at something and said, well, you know, why do you think we get integration wrong? And I said, well, the challenge with integration is we all want to go big bang. We want to go straight for full integration. And the difficulty is, it's a bit like going on a date. Could you imagine if you were on a first date and somebody proposed to you? Now, 1 out of a million times, somebody will say yes. 999,999 times, you're running a mile if somebody proposes to you on a first date. And it's like that with integration. Start small. Start with something where you can actually start to work together and test the elements of it. We're not going to suddenly put all our budgets together and collapse all our organisations into a single one overnight, because that's hard and scary. But actually working together in the interest of service users to deliver better care, that's something we could get together on. And then the other thing I would say is, wherever you go, you find ordinary people doing extraordinary things. Do you truly, really understand who is doing good work in your area? So even in the most challenged areas with the most difficult circumstances, I find some amazing stuff. And I would encourage anybody in this room to go and seek the great people you've got locally, who you probably don't even realise are there. I talked to one home who were doing some really amazing things, and I said to them, you do realise what you're doing is truly innovative and really exciting. And their response to me was, doesn't everybody just do that? Because they didn't know that other people didn't do that, because they didn't talk to anybody. And so do have conversations today. It's nice to come to a conference. It's nice to get a certificate. It's nice to listen to speeches. But actually, frankly, you're here to take something back with you. And if you don't take something back with you from today that you then apply in your local setting, you've learned nothing. It's just as all getting in a room and using public money badly. So use today to learn and take something back with you. So what have we learned about spread? Well, firstly, most people want to do this. Most people understand that this is really human and can really make a difference. Most places have really good foundations on to build on. So if you're thinking of doing this, don't get rid of what you've already got. Build on the good stuff that already exists in your area, and I can pretty much guarantee you that you will have something good going on just about everywhere. In most places we go to, we find that the care model part, so the clinical bits of this, are actually much more in place. They're just not particularly well coordinated. So really thinking about how you get the commissioners to buy into this and get the buy-in to think about this as a system-wide approach is critical. And then finally, getting people to come together really makes a difference. Just have a conversation. Some of the best stuff you'll hear about today didn't start with an agenda, didn't start with a meeting, didn't start with a project plan. It started with a simple conversation. So I'm going to leave you at that. Thank you.